Welcome to the MediByte channel. As a healthcare professional here at MediByte, I am super excited to jump right into today's explainer. We are diving into a really crucial topic, navigating specific labor and delivery complications. We're going to break down exactly how modern medicine identifies and safely resolves them. Today, we're looking at two very distinct scenarios. One is microscopic and hidden, and the other is a highly visible physical challenge.
Okay, here's our agenda for today. 1. Complications of labor and delivery. 2. Defining intraamniotic infection. 3. Infection risks and complications. 4. Diagnosis, treatment, and prevention. 5. The physical hurdle, shoulder dystocia. And 6. Resolving obstructions safely. Let's just dive right in.
Section 1, complications of labor and delivery. To start off, we really need to ground ourselves in the reality of childbirth. While birth is an entirely natural process, complications do occasionally pop up that require immediate, highly skilled medical attention.
Think of it like this. On one side, we have invisible complications. These are microscopic bacterial infections that manage to bypass the body's natural defenses, like cervical mucus and fetal membranes, and they threaten the sterile environment of the uterus. Now contrast that with visible complications. These are actual mechanical or physical roadblocks right there in the birth canal, like a baby's positioning or size, that literally halt the delivery process. Comparing these invisible biological threats against the visible mechanical hurdles really helps us understand the dual nature of obstetric care. Section 2, defining intraamniotic infection. Let's zoom in on that invisible threat first and see how it develops into a serious medical condition. So, let's establish exactly what this is. Intraamniotic infection, which is also known clinically as chorioamnionitis, is an infection and the resulting inflammation of the tissues surrounding the fetus. This whole shebang can involve the amniotic fluid, the placenta, the membranes, or even the fetus itself. The big takeaway here is that many different kinds of bacteria actually live naturally and safely in the vagina, but if those bacteria manage to breach the body's defenses and spread upward into the usually sterile environment of the uterus, well, that's when they cause this infection. And time is literally of the essence here. The longer the delay after a mother's water breaks, the higher the risk for an intraamniotic infection. At 0 hours, you might have pre-labor rupture of the membranes, often called PROM. This removes a massive physical barrier. As hours pass, that delay between the rupture and the actual delivery steadily increases the likelihood of bacterial growth. Add even more hours with prolonged labor, or say multiple necessary pelvic exams by your doctors or midwives, and you inadvertently risk introducing those vaginal bacteria deeper into the uterus. Now, it's not just about the clock. There are a few other triggers to be aware of. Preterm labor, so labor starting early, is a pretty significant risk factor. Another is the presence of meconium. That's the dark green fetal stool, sometimes passed before birth, showing up in the amniotic fluid. Having unscreened bacteria in the genital tract, often just due to a lack of routine prenatal care, also raises the danger level. And though it's rare, the use of internal fetal monitoring, where a tiny electrode is inserted through the vagina directly to the fetal scalp, can sometimes introduce bacteria and breach those defenses. Section 3, infection risks and complications. So what happens if this infection actually takes root? It dramatically changes the risk profile for both the expectant mother and the newborn. It's a huge dual threat. Looking at the fetal risks, it doesn't just trigger preterm delivery. It exposes the baby to severe oxygen deprivation, body-wide sepsis, pneumonia, meningitis, seizures, cerebral palsy, and tragically, even death. And the maternal risks are just as intense. The mother faces threats of severe bleeding or postpartum hemorrhage, a sudden need for a cesarean delivery, pus abscesses, dangerous blood clots in the legs, placental abruption, and serious bloodstream infections. This is why immediate medical intervention is absolutely critical. If left untreated, this localized uterine infection cascades fast into life-threatening body-wide responses for the mother. We're talking about septic shock, which is a life-threatening drop in blood pressure, or disseminated intravascular coagulation, a really severe clotting disorder that paradoxically causes both clotting and bleeding, and acute respiratory distress syndrome, where the lungs just fail to provide enough oxygen. It's a true medical emergency. Section 4, diagnosis, treatment, and prevention. Okay, time to fight back. Let's look at how our healthcare systems proactively diagnose and combat these invisible invaders. You're probably thinking, how in the world do medical professionals detect a microscopic invader quickly enough to intervene, especially in the middle of a chaotic delivery? Well, they essentially play detective, combining clinical symptoms with concrete medical tests. They're looking for clinical red flags first. A maternal fever is the most common sign. This might be paired with a rapid heart rate in either the mother or the fetus, unusual abdominal pain, or a foul-smelling vaginal discharge. If they spot these, they move straight to the medical tests. They'll order a complete blood count to look for a spike in white blood cells. They'll do careful physical exams, continuously monitor the ruptured membranes, and if the diagnosis is still a bit fuzzy, they might even analyze the amniotic fluid directly through amniocentesis. Once they know what they're dealing with, boom, the medical team springs into a highly coordinated response. Step 1, administer intravenous antibiotics immediately to fight the bacteria. Step 2, give medications, usually acetaminophen, to lower the mother's fever and stabilize her temperature. Step 3, expedite the delivery. If labor hasn't started, they'll induce it. What's really crucial to note here is that an immediate cesarean delivery is not always necessary. Actually, if both the mother and fetus are stable, vaginal delivery is still the goal while under antibiotic protection. But hey, prevention is always better than treatment, right? The magic number here is 35. Routine screening for Group B streptococcus is standard practice at 35 to 37 weeks of pregnancy. By catching and treating harmful bacteria before labor even begins, doctors proactively close the door on a major pathway for these intraamniotic infections. Section 5, the physical hurdle, shoulder dystocia. All right, let's completely shift gears from the biological, microscopic world of infections to a purely physical, macroscopic complication. Unlike an infection that builds up slowly over time, this is a sudden physical roadblock. Shoulder dystocia occurs when the baby's head emerges, but then the baby gets caught in the birth canal because one shoulder becomes lodged against the mother's pubic bone or her sacrum. The head might even pull back slightly into the vagina. This is terrifying because the birth canal is now putting massive pressure on the baby's chest and the umbilical cord. That means the baby can't breathe, and oxygen levels in the blood begin to drop rapidly. Now, shoulder dystocia isn't incredibly common, but certain factors definitely up the odds. For the baby, risk factors include being a very large fetus or a history of a prior delivery with dystocia. Maternal risk factors include obesity and diabetes, and finally, delivery risk factors involve difficult, unusually long, or even unusually rapid labor. It can also happen in deliveries that require the assistance of a vacuum device or forceps because the baby's head hasn't fully descended. The resulting trauma from this complication is incredibly physical and honestly sobering. For the baby, the primary threat is decreased oxygen from that cord pressure, but there's also the physical risk of broken bones during delivery or a brachial plexus injury, which is damage to the specific nerve network sending signals from the spinal cord to the arms and hands. For the mother, the intense physical trauma can lead to postpartum hemorrhage, severe tears that can extend to the anus, muscle and nerve injuries in the groin, and in some cases, even the separation of the pubic bones. Section 6, resolving obstructions safely. Let's look at how doctors are specifically trained to handle this exact physical hurdle. Because just like with infections, there is a very strict protocol. When this happens, literally every second counts. The medical team jumps into a rapid mechanical protocol. First, the doctor will quickly try a series of specialized physical maneuvers to free that lodged shoulder and allow the vaginal delivery to continue. Second, an episiotomy, which is a surgical incision to widen the vaginal opening, might be performed just to give the doctor a little more room to work. And third, if those physical techniques just aren't working, they have to pivot instantly. The baby may be carefully pushed back into the vagina and an immediate emergency cesarean delivery is performed. The big takeaway from our sources today is actually super reassuring. Whether you're facing an invisible bacterial threat that's slowly multiplying or a highly visible, sudden physical obstruction, modern obstetric medicine has established rapid protocols ready to go. For physical blocks, it's swift maneuvers. For infections, it's antibiotics and stabilization. The overarching goal is always exactly the same, protecting both the mother and the child through decisive action. So I'll leave you with this question to ponder today. How does understanding these invisible and visible hurdles of labor empower your own healthcare journey? Knowledge is for sure your absolute best tool for navigating the medical system safely. If you found this explainer helpful, please hit that like button, share this with any expecting parents who might benefit from it, and be sure to subscribe to the MediByte channel for more deep dives into your health. Thanks for joining me today, and stay informed.